The topic of the talk today is going to be robot-assisted total hip arthroplasty. It's a technology that I've incorporated into my practice over the last year. I've been very happy with the outcomes of using this technology. As you may or may not know, my name is Hunter Hamilton. I'm a fellowship-trained hip and knee specialist. Primary office is Park West. Also have an office at Oak Ridge. Other information about me can be found on my website, which is hamiltonhipandknee.com. See if I can get this trend. There we go. So I have no relevant financial disclosures. I do want to thank Stryker Orthopaedics for providing some of the slides in this talk. A little bit about me. I went to med school, or rather undergraduate school in Nashville, Tennessee at Belmont University, medical school in Memphis at University of Tennessee, and did 5 years of residency at University of Kentucky in Lexington doing orthopedics. And then I completed my training in Manhattan at the Hospital for Joint Disease, coupled with the fellowship with the Insall Scott Kelly Institute. A quick outline for today. We'll review quickly and briefly normal hip anatomy. We'll discuss some common causes of hip pain, specifically intra-articular causes. We'll review some non-operative treatment options, and then we'll go on to discuss hip replacement surgery, followed by a brief overview of recovery. So these are some illustrations of the pelvis and the hip. On the left, you see an illustration of the pelvis with a right and left hip in their native position, with the femoral head, which is here, the top part of the thigh bone, in its position within the acetabulum or within the cup of the pelvis. On the right, you see a dislocated view that gives more detailed I guess, schematics or information, where you have the cartilage on top of the femoral head. And then inside the cup, you also see cartilage, which is essentially the cushioning of the joint. It allows for a low friction range of motion about the hip that is pain-free up until it's not. You know, our joints are involved in essentially every activity we do, anywhere from working to participating in leisurely activities or exercising, as well as even at sleep. When you have a painful hip or knee, this can limit your ability to do any or all of these things. There are many common causes of pain with respect to the hip. When focusing on intra-articular causes, the most common would be osteoarthritis. This is a wear and tear phenomenon. Essentially, the tread on the tire is thin. Over time, our bone adapts and becomes hard in portions of the bone. And then if you look in this x-ray, you can see the little kind of white lines with the clear central area, which are bone cysts that are a response to having arthritic changes. Over time, the ball can become misshapen, and we lose motion and have pain with activity. Patients often say that at the end of the day, their hip is more painful than in the morning, or after they walk for a little bit, that they start having more pain. Another common cause would be rheumatoid arthritis, and this is different in that it's an autoimmune disease in which your immune system attacks the lining of your joint. This can cause inflammation and remodeling of the bone and deterioration of the bone, which can be very painful. Another common cause of arthritic or painful joint that I see often is post-traumatic arthritis. You can see where at the time of injury, when you have trauma around the hip, the damage can be done at that time to the cartilage, but manifests many years later. Also, if if the bones aren't able to be put back together in their normal position over time, you can develop arthritis that's a result of having that trauma, maybe sometimes even many years ago. And then finally, a cause of hip pain that I see fairly frequently is something called avascular necrosis. This is when you have a loss of blood supply to the ball of the hip joint. And over time, as the body remodels and responds to this blood loss, you can have softening of the bone, and essentially you can have collapse, where you end up with this square peg in a round hole, basically. And this primarily involves the ball side of the joint, but over time, with deformity, the cup side of the joint can also start to develop some degenerative changes. And so when we have hip pain, there's a lot of non-surgical treatment options. Uh, Walking aids such as a cane or a walker can help take pressure or force off the joint. You can use heat or cold therapy to provide relief, from inflammation or muscle tightness. Physical therapy can help improve your overall mechanics. It can help provide strengthening around the joint, as well as try to maintain some flexibility. From a medication standpoint, anti-inflammatories are the gold standard. Medicines like Advil or Aleve or other prescription-based anti-inflammatories um, are the treatment of choice because they address the inflammation, which is really the primary source of the pain, as well as they provide pain relief directly. Another option from a medication standpoint would be a corticosteroid injection, which is delivered directly into the joint. And this gives kind of an anti-inflammatory focus to the joint specifically. Weight loss is something that also can help prevent or help with some of the pain you have with your hip. Our hips and our knees see 4 times our body weight. For every 10 pounds you lose or gain is essentially 40 pounds of force you add or take away from the joint. And these things can be excellent for treating hip arthritic pain. However, over time, these can fail. And once these are no longer providing the relief you want, then you need to start thinking or considering other options with respect to arthritis. It would be a joint replacement. And I see this every week in my clinic, and we'll have this conversation multiple times a day. And essentially comes down to, is your hip affecting your ability to do the things you enjoy? Are you unable to do the exercising you want to do? Are you having difficulty getting dressed? Is it hard to sleep at night? If the answer to any of these questions are yes, then you need to consider hip replacement. It's an excellent option to address the pain definitively. Our conservative measures are not able to build the cartilage back up on the joint. The only final treatment will be a joint replacement. So a joint replacement works by essentially removing the bone from, or the arthritic diseased bone and the diseased cartilage from the cup portion of the pelvis, and on the top of the thigh bone, we implant essentially 4 components. It's a cup that goes in the pelvis, a liner that goes inside that cup, and then we put a stem down the thigh bone, and then put a ball on top of that stem, usually made of ceramic or metal. And then our new joint is essentially the plastic liner with the ball, and provides a low friction, painless joint. There are many approaches to accessing the hip joint. You can go from a posterior approach, a lateral approach. I prefer a direct anterior approach. This is where a incision is made on the front part of the hip. It's usually 3 to 4 inches long. This allows me to go between the muscle planes instead of cutting through them. I'm also able to carry out the surgery without having to dislocate the hip, which ultimately leads to less trauma to the soft tissue while performing surgery. I think studies would support that over the first 2 to 4 weeks, there's a significant increase or improvement rather in rehab potential and a decrease in overall pain coming out of the OR. Ultimately, the goals of hip replacement, or the 3 main goals we have, are going to be restoring the hip center, which is the center of rotation within your hip. We want to put that back to the way God made you, essentially. We want to restore the offset, which is going to be the distance from the center of the hip to the thigh bone. And we have muscles that attach to the top part of the femur to the pelvis. And we want to apply appropriate tension to those muscles to help with normal range of motion and kinematics. And then also we want to restore your leg length. Oftentimes with degenerative changes, you lose height in that affected extremity. As we stated before, it's a wear and tear phenomenon. You've lost cartilage, which effectively makes that limb a little bit shorter. And our goal with surgery is to restore that back to the normal position. And hip surgery has been going, and modern hip replacement has been performed over the last 50 years, initially in England and then over in the United States. And it's an excellent surgery. I think overall satisfaction rates are 93%, which begs the question, and the topic of the talk is why, if it's done so well historically, why do we need to make improvements with adding current technologies? And I hope to convey that to you today. Traditionally, in order to carry out our three goals of restoring hip center, offset, and leg length, we would use two-dimensional imaging and plan our surgery. On the top left, you see where somebody had printed out an x-ray and laid essentially a stencil over it and tried to plan for the appropriate size implants and try to carry out the goals of surgery. On the bottom right is a fairly more modern way of doing this with computer software. And these have been good, but they're not perfect. There are some issues with having your x-rays be the appropriate magnification. And we've taken measures to try to improve that. However, they are not foolproof and oftentimes leaves the surgeon needing to make changes in the operating room. Which leads me to more recent technology, which I believe has made a significant impact in our ability to carry out our three goals of surgery. This is with the MAKO robotic hip replacement. And so what happens is you get a CT scan of your hip prior to surgery, and then I take that software or take that scan and plug it into a program that allows me to template and plan your surgery in a three-dimensional format. It allows me to assess for any bony abnormalities that x-ray may not be able to assess. If you look here on the bottom left, there is a green outline, which is the planned position of the cup portion of the hip replacement. The ball is the planned position of the hip center. And it's hard to see, but underneath that is a pink dot, and that is the patient's native hip center. So you're able to restore this back to its native position. Another benefit is that we are able to assess the bone more in a higher detail, which means we can plan for putting smaller components in, ultimately preserving bone. And on the right, you can see where we're also able to use three-dimensional imaging to plan the position of the stem, which helps us restore the offset, which again is the distance of the thigh bone or the femur from the hip center. And then ultimately, we can take that plan and make a computer-generated x-ray of what our hip replacement should look like. And this is a view that we are very comfortable looking at, as this is how we follow up our surgeries and evaluate our patients after surgery. On the right, you can see what we're looking at prior to surgery, or as we go in to perform the surgery. The green area shows the amount of bone that we're going to need to remove in order to carry out surgery. In order for the robot to know where your pelvis is in space, we do attach essentially an antenna to the pelvis. And we'll discuss why this is helpful in the next couple of slides. But this allows the robot to know where your pelvis is in space at all times. And one of the bigger concerns with the hip replacement is stability. Anytime you have a hip reconstruction, there is the risk of dislocation. And so our goals of surgery ultimately come down to our desire to restore the hip to its native position and provide a stable hip. We have known over time, or developed some criteria over time of safe zone as far as the position to put the cup. That has lended itself to having a lower risk of dislocation. However, this can be problematic in the OR as the pelvis rotates or moves while we're performing surgery. And sometimes the cup can go into a position that you don't really appreciate that it's in. Also, with deformity and degenerative changes over time, or maybe congenital abnormalities, the bony landmarks inside the pelvis are not quite as identifiable and can make this challenging. And so using a robot-assisted surgery with that antenna on the hip and having the ability to three-dimensionally restore your normal hip center of rotation, we're able to carry this out much more successfully. On the bottom left, you see a study where they looked at the placement of their acetabular component, or the cup, compared to a conventional technique, and they were very successful in positioning this cup within the safe zone, or their desired templated zone. On the bottom right, there's another study where they looked at cup positioning There's a square in the middle, which is essentially the target zone for the position of the cup within the pelvis. And the green dots are where they place the cup by conventional measures, and the blue dots are where they place the cup using the robot, which was much more accurate. And ultimately, this leads to overall better stability and hopefully a more natural feeling joint. And then looking towards the future, a new kind of area of study is looking at the way the spine is associated with the pelvis. And so we know that we are learning that the flexibility of the spine overall contributes to hip stability. And if you look at the x-ray on the top, this is a patient that is standing and sitting. And there's the horizontal line here, which is constant. And then this slanted line, which shows us the position of the pelvis as it goes from a standing to seated position. And you can see that it's more flat here compared to here, which indicates that this is a mobile, flexible spine, essentially a normal spine. No special changes would need to be made in the OR for this type of patient who has this much functionality and mobility in their spine. But on the bottom, you see the same constant horizontal line and then the slanted line. And as this patient goes from a standing to seated position, there's only a 6-degree change, which is indication that the spine is very stiff and is a higher risk of dislocation. And future studies are trying to aim at a better position to put the cup in order to prevent dislocation. And one of the nice things that MAKO is in the process of developing is a way to incorporate these images, and then while in the operating room, do a computer generated animation essentially to assess for any problem areas that could put the hip at risk for dislocation through their motion. So it can simulate a standing to sitting position, so we can make small changes to put the hip in the most stable functional position for the patient. Overall, I think there are many benefits to MAKO. I'm certainly happy with the outcomes that my patients have had with this procedure. It helps us put the components in a position that we plan. We're able to do 3-dimensional planning beforehand and anticipate any complications or any challenges, I should say, before going into the operating room. We're able to put the hip back into its natural position, which provides a natural feeling hip for the patient. We're able to remove less bone so we can keep healthy bone within the pelvis. And we're able to just be more accurate overall. Now, after surgery, everyone recovers at a different pace. I tell all my patients, I want you on a walker for 1 week. I would like you on a cane to follow that for 1 week, and this is a minimum. Some patients need a walker longer or a cane longer. You're usually in the hospital either discharged the same day or discharged within 23 hours. And I say at 3 months, ultimately you're 85% recovered from surgery. Now you're feeling much better much sooner, but as far as getting your strength back and your confidence back, around 3 months, you're 85% there. Ultimately, our goal is for you to get back to doing the things you love or need to do. One thing I always joke with my patients is a hip replacement is an excellent way to keep you on the golf course, allow you to swim or bike, but it's not going to improve your handicap from what it was prior to having hip pain. But it is able to allow you to keep an active and healthy lifestyle. I guess that's going to close the talk here. I'll look and see if there's any questions. From anybody.
Thank you, Dr. Hamilton. I wanted to just kind of let you all know of kind of what will happen after this talk today. So as Dr. Hamilton said, if you have any questions right now, go ahead and put them in the chat box. Make sure you're putting them to everyone, not just Hunter Hamilton. That way everyone can see your questions. He can see that as well. But following this presentation has been recorded.